Okay, so we've got 5 minutes for you to give us your presentation. We'll give you a 1 minute warning when you're almost out of time, and then there'll be 10 minutes for us to have a discussion. So what would you like to tell us about your patient today?
First, let me introduce to you the patient. This is Mr. Jones. Mr. Jones has been coming to the clinic for about 18 months now. The gentleman is 64 years of old and he's currently in employment. He's in employment as a window cleaner. His main reason for coming to see us today is he's presenting with painful callosities on the second and fifth metatarsal phalangeal joints on the plantar aspect of his left foot, I beg your pardon, on his right foot, and he's also getting callus on the plantar aspect of the interphalangeal joint of the first toe on the right. Before I go any further with that, I just would like to give you the background of his medical history. The gentleman has been diagnosed with angina. That was 3 years ago, and at the point of diagnosis he was admitted and has had a stent put in place. He's had no further angina incidents since that time, but he is currently taking his GTN spray. Yeah, he has it. He hasn't needed to take it. He's taking GTN spray, and he's also on atorvastatin. They've recently been monitoring his blood pressure as a result of this, and he's recently been put on to ramipril, and unfortunately, as an ACE inhibitor is a relatively new drug, he's getting a little bit of disturbance in sleep because he's getting that ramipril cough, and I've advised the patient to just mention this next time that he's at the GP's. If I haven't mentioned already, the gentleman is a smoker, and was advised to reduce his smoking when at the time when he had the stents put in place, and he did reduce from 60 cigarettes a day to 40 cigarettes a day, but that's still quite a significant number of cigarettes that he's smoking. If we come back down to have a look at his feet here, on non-weight bearing assessment, on the right foot, when I did range of motion at the metatarsal phalangeal joint of the first, I found that to be restricted. So it was restricted to approximately 5 degrees, giving me an indication that we have got functional hallux limitus. I beg your pardon, my error, a structural hallux limitus taking place there. On the left foot, there's hallux adductor valgus present, and whilst there is more movement available at this particular joint, the alignment is out of true. So whilst he's able to pulse forward and go on through third rocker, it's not going in appropriate alignment, and there is some probable low gear that's going on there. No evidence of venous insufficiency, but given the history of the angina and the smoking, I undertook a vascular assessment, and all pedal pulses were palpable, but they weren't particularly strong. The gentleman did talk about pain during exercise, which made me query claudication being present, but the distance that he gave me was something like a mile, so I think that's probably much more kind of sort of almost orthopaedic in origin, rather than it being a vascular or an arterial compromise that's taking place. In terms of the kind of further investigations for management, because he's got the hallux adductor valgus on one foot and the hallux rigidus on the other, it made me wonder about whether or not there was a leg length discrepancy that was going on here. Further interrogation about the hallux limitus that is there is the patient does give a history of having that foot traumatised. He was stubbed rather badly, and he was off work for a little bit of time. That was about 10 years ago now, so I think that limitation that is present, thank you, that limitation that is present is probably traumatic in origin. The fact that there's unilateral hallux adductor valgus makes me wonder whether or not there is a leg length discrepancy there, so I would want to be carrying out further assessment with respect to that, and ultimately with a view to undertaking sort of orthotic intervention and self-management for this patient, because he's currently in work and we want to minimise the amount of time that he's having to come into clinic for self-management of us, and in terms of the orthotic management, I'm not quite there yet.
Thank you. So thanks for your presentation. You've given us quite a lot of detail there, but there's just a few things I'd like to explore a bit further with you, and then Pamela will have a few questions for you as well. So the first thing is, you mentioned your patient has complained of painful lesions on the plantar aspect of their foot. Can you just expand for us why you think those lesions are there?
Well, through the assessment, it was identified that they had got a structural hallux limitus, so you're not getting the required dorsiflexion taking place at the hallux during gait, so in that third rocker is impaired. So then what is then going to happen as a consequence of that you're going to get loading, which is going to go off through the first interphalangeal joint, which just isn't designed to take that load. And I didn't say in my presentation, you can actually see there's a little bit of hyperextension that's taking place of the distal phalanx. So it's going to offload through that particular point, and then it's going to also offload onto the second metatarsal head as well. But there's an element of probably going off onto more of a low gear propulsion, so it's coming off of the lower, I beg your pardon, the lesser mets, because you can't get that rocker through the first metatarsal phalangeal joint. And the other additional thing with this particular gentleman is that he's a window cleaner, so he's up on ladders, so some of these lesions possibly are a little bit more painful, particularly on the plantar aspect, than they might otherwise be, because he's standing on the balls of his feet a lot when he's on the ladders.
Okay. So you mentioned not enough dorsiflexion.
Yeah.
So what would you typically expect to find? What would be the normal range of motion?
In a fully functional first metatarsal phalangeal joint, you can get up to 90 degrees of dorsiflexion, 70 to 90, and in normal gait you require 50.
Okay. So you mentioned in your presentation, so this is us on the right foot. You also mentioned that there's the possibility of a leg length discrepancy. So you've noted there was a unilateral presentation of HAV. Could you explain to us the sort of typical compensation for a leg length discrepancy and whether that's evident in this example here?
The reason that made me think about the leg length discrepancy is because we've got this kind of unilateral presentation of the hallux adductor valgus, which is often associated with an overpronating foot type, and that overpronation will have the effect of shortening a limb. So what led me to think that there might be a leg length discrepancy there is that if you've got leg length discrepancy, you will often try and get there'll be a sort of a bit of a shortening of the longer limb through pronation, and a lengthening of the shorter limb, and that can be through either supination or plantar flexion at the ankle, so sort of like kind of equinus position. Because this gentleman's also got callus on the plantar aspect of the foot with hallux rigidus, I was thinking maybe that there was a little bit more going over to the supination, but I haven't undertaken an assessment of leg length at this point. When you come up to question me, but I could measure.
How would you do that?
Well, the measurement of leg length discrepancy is kind of variable, but you can do it from umbilicus to medial malleolus, or you can do it from anterior superior iliac spine to medial malleolus. You can do kind of a bit more of a crude clinical measurement of getting your patient laying back and then sitting with their knees together with their knees flexed to see if there's a difference at sort of knee level and kind of ankle level. But I haven't undertaken that yet.
Which one are you planning to do today?
I probably feel more comfortable doing anterior superior iliac spine to medial malleolus.
Okay. So you mentioned just towards the end of your presentation, you just sort of you finished off by saying the orthotic intervention, but you didn't really give us any detail.
No, I was just a bit kind of conscious of running out of time. So
So could you expand on what your management would be orthotically?
The primary presenting complaint for this gentleman are these painful lesions, and because it's a structural hallux limitus, we're not going to get any more movement in that hallux. So a functional intervention that you might use for a functional hallux limitus is not going to be of benefit. And so what I'd really be kind of looking to do is to redistribute pressure and offload those particular painful areas that's going on. I would also be advising the patient on some management of symptomology by using kind of pumice stone and things like that on the lesions. But if there is a leg length discrepancy there, what we could do is put a heel raise in to the shorter limb, but the problem with that one might be that it might throw more pressure over onto the metatarsophalangeal joint area where we've already got a lesion on the 5th and on the 2nd, but that might help sort of balance things out a little bit better. Or we could use a rocker. The possible issue with using a rocker sole with this gentleman is that he's up and down ladders for his work, and if you did a rocker outsole, that might cause him to slip off of the ladder. I've not kind of experienced that before, but it was something that I was thinking about. So even maybe possibly for his work shoes, it might be something like an orthotic, you know, with padding that cuts out around the 5th and the 2nd.
What sort of material would you?
I'd want to use a high density material.
Such as?
For doing that. No, sorry, the names of the material's gone, but
okay.
I would be wanting to do deflection.
Okay.
Would be the principle, you know, and could even possibly try that out on a very, very short-term basis using semi-compressed felt, but that's literally to see how the patient tolerates that. Yep. But that will flatten in a matter of days, but that might just be a short-term intervention to see how he actually tolerates it.
Okay, so Pam's got a few questions for you.
You gave us a very comprehensive overview of the clinical picture relating to the cardiovascular history, as well as an overview of the arterial markers, but I'm keen to explore your understanding of the common denominator between these two elements.
I'm sorry, could you rephrase that for me?
Okay, so Mr. Jones presents with a history of angina, as well as some reduced peripheral arterial markers which you've previously identified. Can you identify the relationship between these two elements?
The fact that the gentleman has got angina and has had stents for this, it's an indication of atherosclerotic disease taking place, and that in combination with his hyperlipidemia and his hypertension means that he's at greater risk of getting atherosclerosis, and you can also see atherosclerosis in the lower limb. Big contributing factor to all of that actually is his smoking as well. When we checked his pulses were there, but they weren't particularly strong. So that's maybe giving an indication that the flow to the lower limb is somewhat impaired because of these sort of atherosclerotic changes. And in smoking, you'll tend to see that it's a little bit more sort of kind of proximal in the arterial tree. He's had great success from the introduction of the stents in the heart because he's been asymptomatic from his angina for the previous 3 years when he had those stents put in place. I think one of the other things that we need to really encourage with this patient is the reduction in further reduction in smoking. In discussion with the patient became apparent that there was a real big fright about having the angina and having the surgery, and he did cut back on his smoking. He was asked to cut back on his smoking, so he did come down from 60 to 40, but 40 is still quite a significant amount of smoking, but there hasn't necessarily been the prompt there with further symptomology to kind of be the prompt for him to cut down his smoking further. So I think we want to encourage that. Has that answered your question?
Yeah, and you suggested that Mr Jones was presenting with symptoms conducive to intermittent claudication. What led you to that conclusion?
There's been Mr Jones is getting some aching in his legs when he's walking, but it's quite a distance that he's going before he's getting that kind of aching in his legs. So usually if you're getting somebody who's got problems with intermittent claudication, the distance that they can go isn't very far at all, whereas if I recall correctly it was getting up to a mile. I'm sorry, I can't remember whether I said that or not. So whether it's actually kind of a bit orthopaedic in origin. It's a gentleman who's a window cleaner. He's up and down ladders. He's on his feet all the time. So I've tried to ascertain whether it's a sort of a cramping, stopping you from doing anything kind of pain. A little bit difficult to get right down to the nub of the nature of the pain, and that in itself gave me an indication that it's possibly not claudication at this time.
Okay. And you suggested the need to reduce Mr Jones' smoking intake a bit further. How are we going to facilitate that?
Well, we've had a bit of a chat about sort of further smoking cessation, and whether and so I think we'll need to maybe consider things like smoking cessation groups, the possibility of exploring things like nicotine patches, but using the guidance of the people in the kind of health promotion role with the smoking cessation, using e-cigarettes, whilst not necessarily ideal. We don't necessarily know the long-term effects of what long-term use of e-cigarettes are going to be. We do know that it's better than smoking.
Okay.
Thank you.